So next up, I'm very happy to welcome Monita, and I'm going to bring this out. Give me 1 second. There's your presenter. So Monita is the cultural inclusion lead at St. Vincent's Hospital in Melbourne, a polyglot, twice migrated, and cross-cultural consultant by profession with over 30 years of experience in lecturing, teaching, training of health professionals, clients, and students from a diverse cultural backgrounds in Australia and Canada. Her background includes both the practical and academic side of the cross-cultural experience. Her most recent publications relating to culture and pain is a section in Acute Pain Management, Scientific Evidence 5th edition, entitled Culturally Responsive Care for Culturally and Linguistically Diverse Patients. Presenting on pain and culture, I'm going to hand over to Monita.
Thank you. Oh, good, it works. Muchísimas gracias por la introducción y hoy que vamos a hablar esta tarde sobre un tema tan importante como la cultura, el lenguaje y los dolores. Nou, misschien moet ik het in het Nederlands proberen. Ik wil u van harte welkom heten vandaag dat we gaan praten over pijn en over cultuur. Nee, forse italiano, posso parlare un po' di italiano, no? No. Un petit peu de français, il y a personne qui peut parler. No? Si, oui, ah, très bien. English? This is just a microcosm. It's a silly exercise, but it's a microcosm of what it feels like to be looked after in a language that's not your own. I hope I spoke a language that you're unfamiliar with. And this was just a couple of seconds. But when you are particularly in a moment of pain or in distress, and English is not your first language, you actually sometimes forget to speak it. And it's very hard to find in your brain the space to try and make your situation well known. So thank you for the opportunity to speak to you guys here today. So my name is Monita Mascitti-Meuter. My preferred pronouns are she and her. And I would like to acknowledge and pay my respects to the traditional owners on the lands on which we're gathering here today. I looked it up for the docklands. It's the Wurundjeri, Woiwurrung, and the Bunurong Boonwurrung peoples of Eastern Kulin Nation. So I wish to pay my respects to elders past, present, and emerging. Today, in the little half hour that I've got, I'll be talking, bless you, talking to you about our culturally linguistically diverse communities, particularly our migrant communities. I'll be focusing on cross-cultural beliefs, perceptions, help-seeking behavior, and coping, and also have a little bit of a chance, a couple of minutes on the role of language. It's a big topic, and communication styles when we're experiencing pain. Oops, there we go. And as Julia said at the beginning of my introduction, a lot of the research in this presentation is referring to section 9.3 of the reference manual, but also some other personal experiences of working at St. Vincent's Hospital and so on. So put it in context though, that when we are talking about different cultures and particularly migrant communities, just because someone comes from a particular place doesn't necessarily mean that they will reflect, of course, perfectly all the values and all the cultural norms of where they're coming from. We do adjust, we do acculturate, but today is really about exploring some of the differences that we may encounter in the clinical encounter. Now, talking about culture and language is important because we're very culturally and linguistically diverse here in Australia. Can I have a show of hands here in the room? How many of you are born overseas or have a parent born overseas? Can you have a look around? It's pretty high percentage. The census showed that more than half of us now are born overseas or have a parent born overseas. We do come from about 255 different countries of birth, 350 languages, which actually is not that many. There are about 6,000 we speak in the world, so 350 is actually not a high number. But interestingly enough, of course, with the census, I don't know if you remember the questions, but they ask you what languages do you speak at home? Now, for me, that's a really difficult question because there's some languages that I don't speak at home. I speak when I'm on the phone with my mother, or languages that I only speak with colleagues outside of the home. So it's a bit of a misleading question. And one of the languages that I speak, and I didn't practice that on you today because only 20 people in Australia speak it, that particular language is never registered because there are too few people who speak it. So in terms of 350, that's really ballpark. And of course, with indigenous languages, we are talking about a reduced number every single time we take the census. Languages are disappearing as well, which is incredibly distressing. At St. Vincent's, at our hospital, this translates into, for our hospital, to almost 200 countries of birth represented in our patient population, 41% being born overseas, not born overseas and a parent, straight born overseas. There's a very high percentage of culturally linguistically diverse communities in our hospital. And from our staff, interestingly enough, 64% identify as being born overseas and a parent born overseas. So it is an important matter to discuss within the clinical encounter. I should say here as well, although today my focus is on the cult community, I do acknowledge that, of course, we need to have an intersectional lens when we look after our patients. People may identify as culturally linguistically diverse, but they also may identify as LGBTQA+, or they may identify as coming from a refugee background. For the variable communities, marginalized communities they may form part of. But today's focus is very much on the cult. And to get the ball rolling and to get thinking and diving into this particular topic, I wanted to invite you on a little interactive journey. And the first thing is, I'd like you to have a think about, putting it onto yourself, because part of understanding how we extend care to others is first also thinking about where do we start, how we are. How's our perception of others? How's our experience of pain? So think back when you experienced pain as a child. How were your reports and your expressions of pain managed? Was there very much the brushing off, sort of stoic response, or did you have a lot of fussing over? So how many of you were quite stoic in the response that you got for your childhood pain and trauma? Quite a few. Did you get some fussing? Yeah, a few as well. Let's go to the next one. How did a recent pain experience? So if you had an injury or childbirth or some persistent pain, chronic pain, made you feel and behave. So were you stoic? How many of you are stoic? Often in healthcare, we're quite stoic. Yeah. A little bit more emotive, vocalizing your response. Yeah, a few. Did you surprise yourself? You always thought you were stoic, and then all of a sudden there's this voice that came out of you. You didn't know where it came from. It can be varied. And people around you probably responded differently as well. The last one, and that's sort of, I don't know why it came out all squashed. I think because my presentation was for a broad screen rather than a small one. But think about how you react differently to your partner and your children and your immediate family at home versus your patients. Do you tend to be a bit nicer to your patients? And at home, you're going, oh, you got to be kidding me. I've seen so much worse. You'll be fine. I've had colleagues say, oh, well, in the end, it was a broken bone my son had, but really, I thought he was so exaggerated. I knew exactly, no, we can treat that's fine. I've seen so much worse. You'll be fine, kind of a response. And it's interesting how that's organizational culture or your work culture that will influence how you then perhaps look at patients differently, but certainly treat your family differently as well. And then that layer of, well, in that interaction, did we think about the influence of culture, ethnicity, communication preferences, migration experience, religion? There's a little bit of that layer as well that sometimes plays out. Now, in terms of the research that's done in that space, probably as far back as the 1950s and 60s, that link between pain and culture was made by the anthropologist Mark Zborowski. And what he ended up saying is that pain wasn't just a neurological, physiological experience, but also something that was socially learned. And he started linking those two together. And we only have to look at language to understand that that's the case. If you look at, for instance, how pain is translated in Spanish, dolor, it's translated and it means not just pain, but also grief. In the case of Japanese, pain is translated as itami, which translates to both physical and emotional pain. And in French, we use the term douleur That is the intensity and duration of pain that it refers to there as well. If we go into the pain beliefs and cross-cultural beliefs, you may have come across perceptions that, you know, it's God's will. And therefore, I don't really want pain relief. It's God's will that I need to suffer. And therefore, people might actually reject and don't want to have any assistance, or that it's punishment, that it's perhaps evil eye. Have you ever come across the sense that the experience or the illness or the pain that someone's experiencing, they see it as something external? So the locus of control is seen as external, which means they don't feel they can do anything about it themselves, and they let it overwhelm them. And so that locus of control influences also how they respond as a result. Very common as well, pain, part of aging. Or that particularly refugee and asylum seeker communities, there's a culture that tends to develop where people seek care reactively. So they present really late at emergency, or they present when it's really that intervention needs to happen. And as a result, you know, there's no proactive way of managing the healthcare. And of course, in some cultures as well, opioid phobia, the fear of taking the medication, the fear of addiction, the fear that, you know, if you mention it at end of life, that the person is going to die right then and there. And so that conversation makes it a little bit harder. And I have to put in here acculturation. So acculturation meaning that we do tend to adjust as well when we migrate, but also it depends whether a person comes from regional areas or urban areas from the country where they're from. So one example, for instance, in the case of Nepal, if you're looking at issues around backache, in rural Nepal, what ends up happening is that people see backache or back pain as normal, part of aging. So not much is done about it. But in the case of urban Nepal, they actually see it as a biological phenomenon and they will seek help. And so there's much more familiarity with the healthcare system and what can be done. With pain and perception of pain, there's a lot of research on this. So they are looking here at particularly that the person's empathy, their ability to perceive pain in the other, that it does differ across cultures, particularly in the work of Zborowski. He interviewed something like 4,000 different nurses, and he found that cross-culturally, across different countries and different cultural groups, it did depend who was looking after you, whether they got it right. And particularly if you're not being looked after in a culture not your own, chances are they were getting it wrong because they were misunderstanding the cues and they were looking for something else. And so there was that misalignment that happened. I do need to say that a lot of the research, cross-cultural research, unfortunately or fortunately, it does tend to focus on the US a lot, on European experience, on East Asia. So there's not a lot being done in the Australian realm of things. So within the US area, they are finding that racial and ethnic differences, it influences analgesia prescription, perceived tolerance as well, and threshold. And in particular, what they're finding is that over and over again, Caucasian patients will get more opioid or better, or sort of a better treatment or a better outcome in opioid prescriptions than if you're African American, if you're Hispanic, or if you're East Asian. In the Australian case, there is an interesting example where they compared Chinese-speaking patients with the Australian cohort, and they were comparing in the emergency department major abdominal surgery. And what they found is that Chinese speaking patients were actually requiring fewer opioids, but their pain scales were higher. Why do you think that might be? It's a tricky one. Could be pain threshold. There is holistic as well. That's one argument too. So there tends to be, particularly in the Asian case, that we, particularly in the Chinese case, will see a balance of Western and Eastern medicine. So complementary medicine going with the Western case as well. In this particular scenario, though, there was a bit of a phobia, a fear. And so patients, because if they had that fear of becoming addicted. They were actually becoming more stoic in trying to manage the pain, therefore not requesting it. Yet their feeling of pain was still quite high. So interestingly enough, what it concludes as a result is that our experience may be the same, the physiology is the same, but how we express it and how it's perceived in us is where the difference lies. And in the Chinese case, the other thing they found was some of the ones who were identified as Buddhist, they felt it was karma building. So being more stoic and feeling the pain was quite important to them as well. So it's a bit variable, but a surprising result when we look at a comparative study like that. And that was closer to home. Now, in the behavioral aspect of it, when we're seeking help, you may have come across scenarios where, and this is just a case study grabbed from the books, a young Vietnamese woman who's not asking for pain relief because she feels it's an imposition to ask a doctor to do something for her, and that her doctor may have been unhappy with her request. So trying to ride the pain, but there are other cultural reasons here why she might not be requesting for that support. Within cultural theory, we like to go back and unpack the various layers of the onion. And one way to explain that behavior is by looking at cultural orientations that initially were purported by Hofstede, Hall, Trompenaars, and so on, to try and understand, well, why is she refusing? And why doesn't she want to bother the health professional? Where is this coming from? The statistics here are a little bit, please don't take them as gold in terms of, everyone born in Vietnam is going to score 2 out of 10 of being, on the individualism scale. So these are the type of statistics you get, how individualistic a particular culture may be. In the case of Australian culture, we tend to score, and I'm not sure whether that's dropped off as well, because it has squashed my slides for some reason. In the case of Australia, we tend to score 9 out of 10 as being very individualist. And it's not talking about our Indigenous community. This is talking about our Western Caucasian, our sort of the dominant, what we're known for type of culture, but 9 out of 10. What that means in healthcare is that it's not surprising in hospitals that we're saying, oh, the patient needs to decide. It's I language. It's all about patient-centered care. The patient needs to be involved. The patient needs to be told, and so on. If you're looking at all the cultures that we're looking after, it's the total opposite. They're collectivist. So it's not uncommon in those cases to say, don't talk to me, talk to my son, talk to my daughter, talk to my husband, talk to my wife, don't talk to me. We call that the passive patient syndrome. Well, it's not passive, it's cultural. Basically, because the group will decide for the patient, the family heals, the family makes the decision, the family tries to take over that responsibility and that activity. So when it comes to decision-making, or when it comes to asking for pain relief, the whole focus is on keeping harmony, keeping everyone happy. So the patient will not ask for that relief, and they will not ask for help. And power distance being the second example of the orientation would be, that's really talking about when you have a health professional here, the patient considers themselves on the level here. And that high power distance means that probably you will not ask for clarification from your health professional. You will very likely not look at them directly because you're sort of, in terms of eye contact, that's disrespectful. Mm-hmm. And certainly there's a lot of nonverbal communication happening in that space as well. And you will be bothering the health professional if you ask for any support. So it's true to say that in a number of collectivist high power distance cultures, you tend to find that patients tend to be more interdependent, or interdependence is preferred. They prioritize well-being of their family over themselves, and they wait before asking for help. Now, when I asked the question around coping, we kept it in the 2 types of responses, very clear, being either stoic or being emotive. So a stoic, keeping everything strong, not expressing yourself. The problem with stoicism is, from a cultural perspective, there are various layers to it as well. So if you look at particularly, probably more introduced by various faith traditions, Stoicism can also be known as spiritual coping or a belief in fatalism. And there might be a fear in some faith traditions of punishment, karma building, and relief tends to happen through prayer and hope, not through medication, through prayer and hope. And that prayer might be meditative, it might be on behalf of someone else. And it's interesting to see how across Islam, how across Hindu and Buddhism, you get various reasons why and how we should manage pain. So particularly if we look at Islamic teachings, and I quote, they emphasize forbearance, silence, steadfastness. Sufferers are advised to refrain from complaints and to welcome illness as if it were health. So when you come from that perspective, the way that you manage pain and the feeling will be quite different. From an emotive reaction, so vocalizing, I know that traditionally we think of particular cultures to be quite boisterous and have their bodies a bit more involved in how they're feeling. Well, we consider that even nonverbal because we're talking tonality of voice, volume, and body language. And unfortunately, that's labeled as catastrophizing. I think that's a Western judgment because it's not catastrophizing. If you've ever been in that situation, it's not to make a situation even worse. What a person is trying to do is invite you in to that dialogue, take over the pain, acknowledge their suffering, and then lo and behold, things might get a little bit more manageable. But catastrophizing, I'd like to replace that more with vocalizing. But unfortunately, in the literature, they tend to use catastrophizing still. As an example, we had a resident not too long ago, I'll de-identify. Her name was Francesca, 76-year-old Italian female, diagnosed with dementia. And one of the problems that they were finding with her, and in the patient notes, you could read that she had agitation and calling out behavior. Now, with agitation and calling out behavior in this aged care residential facility, that meant that the staff in the end just closed the door to her room because they felt it was too distracting to other residents and it was just easier for them not to hear her. The case got referred to an RSP nurse, and what she ended up doing was interesting. For 1 week, she did behavior charts on pain and tried to talk to the family and spoke to the staff. And lo and behold, Francesca was in a little bit of pain. So they managed that. But then they realized it wasn't really going down, the acuity and volume. So there had to be something else. So the nurse ended up investigating Francesca's cultural background, started training the staff, started providing particular language tools like communication cards, as well as Talk to Me and the Call Assist app. She also started providing Francesca with some reminiscence items and providing some Italian music and access to the Italian radio and whatever it was to try and make things comfortable. But also, most importantly, she taught the staff just the basics of hi and goodbye, whatever it was in Italian. And even more importantly, forced them to leave the door open and say hi to her when she was calling out. And lo and behold, the acuity and the volume totally stopped. All that Francesca wanted was to be recognized, to be acknowledged, to have some attention, to have a bit of a chat, and things got so much better as a result. That brings us to language. Now, with language is an interesting one. If you've dealt with patients of culturally linguistically diverse backgrounds and you're working through interpreters, you might ask the question, describe the pain for me. In the case of a headache, you might find in Chinese language, it translates as a painful dizziness or vertigo. Or in Spanish, there is the dolor de cabeza or dolor de cerebro, which is a brain ache or a headache. And then in Nigerian, it seems as if pepper were put into my head. Things like ants keep creeping in various parts of my brain. You think they'd have something else. Or by merely touching parts of my brain, it hurts. We're not sometimes familiar with how cross-culturally we may describe what we're experiencing. And often within English, I put the English slide there of, can you just, is it stabbing? Is it radiating? We have our preferred ways of describing it to a patient, but they might not necessarily be familiar with it. And for interpreters, that could be a little bit of a challenge as well. And in focus groups, even when they were talking about, does it really work when we're using these tools to help you describe, how bad your pain is? One of the focus group people of an Indian participant said, that Indian patients won't be able to differentiate between soreness or pain and severity of it. Pain's pain, it's there. And I know for a fact in the hospital, some patients say, well, if on the pain scale an 8 will get me the medication, I'll say it's 8, or 10, I'll say it's 10. And then the Stoics, of course, get the number totally wrong. Favorite number is 8, so I'll just say 8. So the pain scale doesn't necessarily always work, should always be used in conjunction with other tools. This is one of my more favorite slides. Again, just because cultures are listed in a certain way doesn't mean everyone in France is going to be pegged in that order, but it gives you a little bit of the spectrum, how cultures work when they're communicating. So the preference would be for the top cultures, for the top groups, to be a bit more direct, and what we call low context. What is said is what is meant. There is no way you're going to misunderstand. Sometimes, particularly with the top ones, it'll be incredibly cruel. It'll feel like, quite confronting. To the bottom ones, where there is so little said, so much in nonverbal communication, you have really no idea whether you agreed to something or didn't. So as an example for the real directness, a couple of months ago, I was walking in a dog park. I have a little cavoodle, met up with a Ukrainian lady, also with a dog, never met her before in my life. We had a bit of a chat, as you do in a dog park. So we started chatting along, and after, about 20 minutes, exchanging recipes, turns out she'd been in Australia for 30 years as well. So we had a lot of things in common. We're exchanging, a nice little chat. Then all of a sudden she stopped short and she looked at me and she said, now I'm trying to figure out how old you are. And I thought, okay, good. And she said, well, because your face is young, but you're fat. And I'm going, okay, all right, step back. That's all right. So, but I put it in context. It was, for me, that was a direct thing to do. You don't necessarily tell someone you've just met, but we had established a contact, we'd made connection. And really at that point, we were quite close. And so I thought, well, it comes from a really good place. She's just saying exactly what she means, which is incredibly direct. And luckily my father is Dutch, so I took it as to, okay, all right, I'm in that space now. That's fine. Different too, when you're going into the non-verbal areas, because that gets a little bit tricky. So for one particular work that I did for, I think it was for the Australian government, this is going back a couple of years, some guys were going to go over into Japan and they said, oh, we've got our presentation totally down pat. This is what we're going to do. Can you give us some advice? So I just looked at it and I thought, okay, well, for meetings, you've got to be really sure where you're going to place everyone, because depending where you place a person gives the message to everyone how important they are. So in Chinese and East Asian context, the most important person you put the furthest away from the door, which is me. Yes, that's the door. And the reason being, if there's an invasion, everyone gets killed first, and the most important person stays standing. Actually, you guys are more important than I am. But in terms of how cultures work, that's a nonverbal way in a family meeting. Where they sit gives them that message, how important they are. And nonverbal is eye contact. Nonverbal is spacing. Nonverbal is just simple body language. Nonverbal is also silence. When someone's not answering, doesn't necessarily mean they agree. So sometimes we're so often going through the list, tick, 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 yes, yes, yes. They've said yes, but what they actually said was no. They said yes, but they meant no. You had to read the context. They said maybe. They certainly heard you. So in some studies, they look at facial expressions. This one is a curious one, comparing Western Caucasian with East Asian facial expressions. And what they say is that in the Western case, we tend to focus very much on the mouth area. So COVID was really hard for us, wasn't it? When the mouth area got covered, we had to start communicating with our eyes. So I started reading articles about doctors going, oh, I have to really squint and use my eyebrows to try and make sure that they know I don't mean harm. The focus is very much on the mouth area. In the East Asian case, it tends to be on the eye area. for emotional expression. So that's really, even, you know, when we're looking at a person's face, are we looking at the right parts to get the full message? And if you even look at emoticons, in the Asian case, there's so much more work done on the eye expression. We just focus on the mouth, whether it's smiling or whether it's sad. It's quite simple. So it's you know, just to raise awareness around that. And of course, a lot of this is based on unconscious and implicit bias, but also our training tends to be quite influenced by implicit and unconscious bias. First of all, by the mannequins that we use in healthcare. I was presenting this 2 weeks ago in ED, and there was a white mannequin there. You know, in terms of how comfortable are we to work across various groups, and also when we're doing trials or running any trials in healthcare, they often exclude our culturally linguistically diverse communities because it's just too hard, a little bit too expensive to translate everything, and too complicated. So they are still also deserving to be included. So just a little bit of a plug here for anyone working on trials in that space. That leaves me with our main question. So what do we do? How do we ensure culturally responsive, safe care? I'll give you a do's and don'ts list, but most of you will already be working in this space and know that, of course, if you know, first of all, ask a person what do they like to be called? What's their preferred name, terms of address? Using an interpreter as soon as you feel that language is an issue. Functional English is not necessarily enough English to be able to manage a medical conversation. Using translation tools as an adjunct, combining tools, being respectful, that is cross-culturally also a bit of another chapter for another day, but of course respect is shown in different ways too. Addressing unconscious bias, and that could be also by calling out microaggressions of other colleagues, making sure that whatever you give in health information is inclusive in language, inclusive in images, the way that you present your health service appears inclusive. That's cultural safety too. Be curious, open-ended questions, never closed. Don't ask questions where the answer is going to be yes or no. That's not going to work. You gotta get the story. You got to be able to unpack it. Certainly modify your language. Sometimes we're so used to medical language, but also slang. I still remember my first experience in an English hospital in Canada, where as a 16-year-old, I had to go in by myself. My parents weren't allowed. The nurse comes to me and she says, "You got to pee in this cup." And I thought, where the hell is the vegetable? I have no idea where the pee is. I had never heard the word to pee. I had heard and learned the word to urinate. I had not learned the word to pee. So I just looked at her and she looked at me and I thought, you know, I can speak some English, but I really don't know what a pee has to do with my urinary tract infection. So it was a little bit of a very awkward moment, but it sort of, you know, you need to be able to manage and understand the language limitations as well. Listening actively. I hope you're all very familiar with chunking and checking and the teach back method. Always checking back that things are understood. There are tools out there with culturally sensitive questions, open-ended questions. There are also assessment tools that have been translated. And of course, I need to put in a plug for the Talk to Me app, which is one that I created over the last few years, available in 16 languages other than English, to be used in a subacute setting, but it has a section on pain. And it does help in terms of telling a patient, we're here to help you. The interpreter's on their way, but also in terms of pain, tell me where the pain is, tell me where it hurts on a skill, you know, using your fingers and so on. It's got that translate on it too. Cold Assist does as well, but we've got a few more languages now. So more than welcome for you to try that out. And that's it. So, thank you.
Many thanks, Monita, and such a really intriguing presentation thinking about the different perspectives of pain. And I do note, I'll ensure that the formatting is correct in the slides when they're distributed.
Oh, good.
So that piece. I knew something would get caught in the mix. We do have time for a couple of questions. If anyone in the audience had questions, feel free to raise your hands. I think James has a mic over there as well.
I might ask one to kick us off. I was just, you mentioned the pains. First of all, thank you for a fantastic presentation. And I'm not a nurse. I have no clinical or medical training, but you did mention the pain scale, and I was wondering about your reflections on it as well as the reflections of our audience, because it seems like a clinical tool that obviously has, like, I understand why it exists, but certainly the 1 out of 10, whenever I've engaged with a nurse or a doctor around that, I haven't found it a very useful tool. And certainly the nurses and doctors I know regularly say that someone will say, oh yes, it's 10, or, you know, very calmly either say 10 or be,
I think it's variable. Within the cultural space, we don't really support it. There are issues also with the faces, with the colors, with the direction of reading. So there's an assumption we always read from one direction to the other. So it's loaded with a few assumptions that make it a little bit challenging. So our recommendation usually is use it in collaboration with other tools, and certainly with talking to the family and just getting the story of the patient, how they describe their pain, why they think they're suffering, you know, and actually give it a little bit more information than just a number. And that might help get a better understanding of where it's at. But yeah, generally I've come across people just saying, I'll just say 10. And then people who are very stoic, like my brother going in with a hernia saying 4, because I know I can manage it. But really it was an 8. So it's helpful, but shouldn't be used on its own. Yeah. From a cultural perspective.
Thank you. Did we have any other questions? Or I see there's a comment online from Bridget saying that they used to use the 1 to 100 scale, seeming to give individuals a bit more of that kind of scope and space for ranges.
Then you should also be able to count to 100. So in some cultural groups, we haven't spoken about literacy, health literacy, and numeracy issues too. So in some, and I'm talking more the older generations, they wouldn't have finished primary school in some cases. So there is a challenge, and there are issues with other tools that ask them to do some basic maths, which of course people can do things, but sometimes they haven't had the maths classes before migrating over. So yes.
Oh, I've got one question. We'll call that the last question. Presentation. Thank you, Rachel. Just the mic.
There. Sorry, thank you. One of the, the interesting point you raise about when research is presented, it's always from a westernized perspective, and I mean across the board in most areas of evidence-based research. So how do we apply what we're supposed to use as evidence-based research to a country that's so diverse?
As Australia
in clinical setting, because as you've clearly identified here, we know that our country is not really, we can't really say we're westernized because we have such a diverse range.
Which is why I do try and get particular research that's done overseas. So in other topics where I present, for instance, on end of life considerations and disclosure at end of life, there's enough evidence overseas that in particular cultures, they will still talk to the family first rather than the patient. And so that evidence we then use to implore on staff to also include the family in the discussion at end of life. When it comes to pain, it'll inform somewhat what we need to do in a culturally diverse space. And I emphasize very heavily, or focus very heavily, on the communication side and communication styles, which is more international in its approach. But in terms of Australian evidence of, like the Chinese-Australian comparison, to me, that's gold, but we don't do enough of it. And I hate relying on the US evidence, which is also influenced by its economy and its health system, where there's systemic racism that excludes particular communities from just going to the hospital. So they will be stoic because when they go in, they'll be told to just go home.
The bias is already there.
Correct.
Yeah.
So and that's why it's biased.
Yeah. Really interesting topic. Thank you.
And sorry for it being such a serious matter. I wish I could make it lighter.
No, I think you've done it quite well justice. I think all of those examples and explanations and kind of cases, as you say, there's no one size fits all approach for especially this topic. So I think, you know, you really carried that message quite well. So I'll invite everyone to thank Monita one last time for her presentation.
Thank you.